Good afternoon, everyone. Welcome to our Medscape event. If you haven't already, here are some housekeeping items. The Wi-Fi and passwords on the left. And if you haven't scanned the QR code, that will really help you answering some poll questions and doing the Q&A sessions as well. Today, we're presenting cardiac myosin inhibitors in hypertrophic cardiomyopathy from fast facts to patient-centered solutions. I'm the chairperson today. My name is Hongya Chen. I work as a cardiology pharmacist at University OHSU, Oregon Health and Science University in Portland, Oregon. And to my left here, we have Dr. Nosheen Reza. She is an associate professor of medicine at Penn Center for Inherited Cardiovascular Disease. And then to the left of her is Dr. Rachel Lavelle. She works also as a cardiology pharmacist at University of Chicago Medicine. Today's agenda, we will have 10-minute takeaways with 4 sessions. Dr. Reza will go over the first 2. Dr. Lavelle will do the 3rd one, and I will do the 4th one. That really covers what every managed care pharmacist needs to know about CMIs or cardiac myosin inhibitors. And then after that, we'll go through 3 cases, and these will really help us identify each patient and present with the treatment plan And then we have a little bit of Q&A after that as well. Okay, so we're gonna just dive into it, and I'll let Dr. Riza take over the first two sessions.
Thank you so much, and good afternoon, everyone. I'm so excited to be here with all of you. I don't actually ever really get to attend a managed pharmacy convention, so thank you for welcoming someone like me, a practicing clinician and HCM enthusiast, to your wonderful meeting. I'm excited, as Dr. Chen said, to get to share with you what we're calling the state of the science in hypertrophic cardiomyopathy. I'm going to spend the next 20 minutes or so reviewing what HCM is, and then tell you about a lot of the recent pivotal clinical trial data in this area, and then we'll come back to those concepts throughout all of our colleagues' talks today. So just to level set and get us all on the same page, how do we make the diagnosis of hypertrophic cardiomyopathy? Well, it's made currently as an imaging-based diagnosis. As you can see here, we make the diagnosis when we see an end diastolic left ventricular wall thickening in one or more myocardial segments of 15 millimeters or more in adults, and that's largely the population we'll be discussing today. And in the absence of any other etiology to cause this heart muscle thickening. So those are things like neuromuscular disease, metabolic or mitochondrial diseases, syndromic or other structural heart diseases like aortic stenosis that could cause the left ventricle to become thick. As you can see on the right side of the image, we decrease that threshold to 13 millimeters when we have somebody with a family history of HCM or a positive or pathogenic genetic variant that causes HCM. So this is how we detect HCM, and how prevalent do we think it actually is? Well, using combinations of cohort studies from echocardiography, cardiac MRI, population genomics, and databases using electronic health records or claims, we're arriving at an estimate of about 1 in 500 or so, and various sources you'll read may actually even increase this prevalence to 1 in 250. So historically thought to be a rare quote-unquote disease. As you can see here, the statistics actually tell us otherwise. What we do know also is that hypertrophic cardiomyopathy is underdiagnosed, both in the US and around the world. What I'm showing you here is an estimate of what we've clinically identified in terms of HCM, and that's about 10% of all the HCM that exists per these estimates. So that means we have a large proportion of people affected with this disease that are still underdiagnosed and therefore undertreated. How do patients with HCM present? Well, it can be a wide range of clinical symptoms and clinical events, everything ranging from effort intolerance, shortness of breath, palpitation, and then the development of other complications like atrial fibrillation, heart failure, and thromboembolic events. There are multiple pathophysiologic changes in hypertrophic cardiomyopathy that lead to a lot of those symptoms that I just described and those outcomes. We'll review some of these data again a little bit later in our session, but we estimate now that about 70 to 75% of people with hypertrophic cardiomyopathy have what's called obstructive hypertrophic cardiomyopathy. That means there's a presence of left ventricular outflow tract obstruction, and we quantify that in terms of a pressure difference or gradient. And as you can see here, when we have a pressure difference or pressure gradient of 30 millimeters or more in that left ventricular outflow tract, that's what we consider to be obstructive HCM. Patients with HCM also develop mitral regurgitation as a consequence of the changes of the geometry of the left ventricle, and this hypertrophy exists. Other things like autonomic dysfunction, diastolic dysfunction, and myocardial ischemia, because that thick heart muscle can't get the blood flow that it needs, all attribute to those symptoms and, again, some of these outcomes. And some of the additional things that can happen, again, down the line when all of these pathophysiologic changes combine, in addition to what we talked about earlier, like atrial fibrillation, stroke, and heart failure, arrhythmias, including both atrial and ventricular arrhythmias, can also occur. And again, that's typically what we think of as causing sudden cardiac death. And then other adverse remodeling changes to the left ventricle, including things like left ventricular aneurysm. So I've painted this early picture of we know what HCM is. We are working on how to diagnose it better and better every day, but we still know that there are many, many patients that are undiagnosed and undertreated. And so we have this treatment and diagnostic gap in the disease. So here are what you would think of would be important goals as we're developing new therapeutics. We want to be able to, number one, prevent the development and progression of symptoms, including things related to heart failure. And we also want to prevent structural changes to the heart that could decrease the risk for some of those adverse events we just talked about. So that brings us to our next section where we'll talk about how individuals with hypertrophic cardiomyopathy are treated in 2025 and potentially beyond. So here I'll start by showing you our current contemporary disease guidelines for the management of cardiomyopathies. On the left, I'm showing you the European Society of Cardiology guidelines, and on the right, I'm showing the United States Multi-Society guidelines for the management of HCM. And again, we're just focusing on the treatment of individuals with obstructive HCM, or left ventricular outflow tract obstruction. So as you can see here, both paradigms start with if you have the presence of left ventricular outflow tract obstruction and you have symptoms that are attributable to that left ventricular outflow tract obstruction, then you want to make sure that your patients are not on medications that could exacerbate that left ventricular outflow tract obstruction, like vasodilators, high-dose diuretics. And then your next step would be, per both guidelines, beta blockers. And as you can see in the American guidelines, we have beta blockers, verapamil, or diltiazem, the non-dihydroparentein calcium channel blockers. So there's actually really only been one randomized trial of beta blockers in obstructive hypertrophic cardiomyopathy that was actually just done a couple of years ago. And here I'm laying out the data from that one trial that was done, along with the hypothesis of why we, for many, many years, have treated patients with beta blockers. And you can see, theoretically, we think, of course, beta blockers will decrease the heart rate and contractility, thereby increasing diastolic filling, thereby decreasing left ventricular outflow tract gradient, and then hopefully reducing the symptoms related to that, and then hopefully increasing the maximum ability someone is able to exercise. So in this particular trial was a randomized crossover design in 29 patients with obstructive HCM, and they did 14 days of metoprolol treatment and, of course, did the crossover design. And ultimately what they found was that these individuals on metoprolol did have lower LVOT gradients at rest, peak, and post-exercise. They had reduced degree of exertional dyspnea and angina, but essentially no change in the maximum exercise capacity. So again, leaving a therapeutic gap in what we hope to achieve when we're trying these therapeutics in patients with HCM. So that really sets the stage for what we'll talk about next, line therapeutics. So I've taken those two same guideline paradigms and now added the second part of what these paradigms say. So again, we had initially looked at the first line therapies for both these guidelines, beta blockers, 9-dihydropyridine calcium channel blockers. And then you can see that both guidelines say if symptoms persist, then you can move on. And there's a little bit of nuance here. The European guidelines say your next step may be disopyramide or mavacamten with a class 2A recommendation, the first in class cardiac myosin inhibitor. The United States guidelines recommend either a myosin inhibitor with a class 1 level evidence, disopyramide, or septal reduction therapy, all at that same evidence level. And we'll talk about, again, the interplay of some of these therapies at the end when we talk about our patient case examples. So let's go through the data for that next step, that next line of therapy. We just reviewed beta blockers, so let's talk a little bit about the cardiac myosin inhibitors. So they're drugs that are designed to attenuate this hypercontractility state of the HCM heart. So on the top diagram, you can see the chemico-mechanical ATPase cycle of myosin and actin interfacing in this cardiac sarcomere and where cardiac myosin inhibition fits in. So essentially, where you can see in the first graphic, cardiac myosin inhibition essentially stabilizes the myosin in that super relaxed state and ultimately prevents the power stroke, that contractility state of the actin-myosin binding. So really decreases the number of these actin-myosin cross bridges that ultimately contribute to that hypercontractile state. That is represented on the bottom half of the graph. So now let's take the next few minutes and do a run through essentially of our latest pivotal trials. And again, this is meant to be really not an in-depth clinical trial review of every single trial, because luckily at this point we've been able to generate a lot of evidence for the treatment of patients with HCM. It's actually a really exciting, robust space. But I wanted to make sure to give you all the highlights so you understand in the context of where we've been, how we're using these drugs today, as we'll talk about in our examples, and where we're going. So here are the major clinical trials of cardiac myosin inhibitors to date in HCM. On the left, I'm representing the clinical trials that were performed using the first-in-class medication mavacamten. And we'll also talk about the second-in-class medication aficamten, the evidence for it as well. So let's start with the phase 3 clinical trial of mavacamten versus placebo in symptomatic obstructive HCM. That was the Explorer-HCM trial. And again, we're going to do this at a really high level, but inclusion criteria for this trial were patients with obstructive HCM, as you can see there, of course, symptomatic, judged by New York Heart Association class 2 or 3. And as you can see here, mavacamten in comparison with placebo was able to achieve the primary endpoint of this trial, which was a combination of either an increase in the peak VO2, a measure of oxygen consumption or cardiac performance, what we're using for functional capacity in these trials, along with an improvement in symptoms as judged by NYHA class improvement. So you can see this really set the stage for this concept of feel and function endpoints that we'll keep returning to. That's essentially our goal when we treat patients with HCM. We want them to, of course, feel better and, of course, function better. And here in graphical depiction, I'll just show you the reduction in LVOT gradients, as you can see here, both at rest and with Valsalva. Mavacamten, again, represented in the blue. This trial, as you can see, was done out to 30 weeks. And then safety endpoints included measurements of left ventricular ejection fraction. As you may be thinking, as I showed you the pathophysiology of how cardiac myosin inhibition may work, by decreasing contractility, there may be a risk of decreasing contractility a little bit too much, and there was a concern about reduction in the left ventricular ejection fraction or contractile force. So this is something you'll see echoed throughout all the clinical trials. Measurement of, again, EF is another safety endpoint. As you can see here, the modest reduction in LVEF with mavacamten compared to placebo out to 30 weeks. And then running through additional adverse events and zooming in on that ejection fraction less than 50 cutoff. As you can see here, dizziness and syncope occurred more often in patients with mavacamten versus placebo. And with regards to the EF reduction less than 50%, which was, again, considered the threshold of an adverse event here, you can see that occurred at a higher rate in patients on mavacamten versus placebo, although 3 of those 7 patients were asymptomatic, and the EF recovered after interruption for all 7 patients who are receiving mavacamten. And this is an important point to really hammer home in the care of patients with HCM and on cardiac myosin inhibition, as we'll talk about the therapies in this class. The important thing is these drugs were shown and are designed to essentially have reversal of this LVEF depression after withdrawal of the drug and washout of the drug in the system. So you'll see again this signal of reversal echoed throughout the clinical trials I'll review. VALOR-HCM was another phase 3 study of mavacamten in patients with HCM, this time really focused on could treatment with mavacamten reduce the number of patients who ultimately went on to need septal reduction therapy. That's alcohol septal ablation or septal myectomy because of persistent symptoms with obstruction. That trial was positive, and there were no other new adverse reactions identified in that group. Here we're taking a closer look at that improvement in New York Heart Association functional class out to a longer period of time. So this is now out to 120 weeks, a long-term extension of the Explorer trial. And again, you can see here that large proportion of patients did improve and felt better, and those improvements continued on throughout the duration of this extended study. And then here again, echoing that, what I just mentioned about the VALOR-HCM study, these again were patients who either underwent SRT or remained guideline eligible for SRT as the endpoint of the study. And as you can see here, those guideline eligible for septal reduction therapy in the mavacamten arm dramatically reduced by the end of the trial. So ultimately, mavacamten was FDA and EMA approved for the treatment of symptomatic obstructive HCM, those with patients who were class 2 or 3 symptoms, in order to improve functional capacity and symptoms, as we've discussed. The warnings and precautions include, as we've talked about, the risk of heart failure, clinical heart failure due to the systolic dysfunction. And this is why in the prescribing protocol for mavacamten is echo assessments of left ventricular ejection fraction, and some of our case studies and what we'll talk about will go into this a little bit more. There's also a risk of drug-drug interactions leading to potentially heart failure or loss of effectiveness. So again, that's another real-world concept that we'll map later in our case discussion. And a couple of other things include the use of contraception because of prior studies that have shown potentially for embryo-fetal toxicity. And mavacamten was approved with a risk evaluation and mitigation strategy, or REMS program, as you were all familiar with, again, largely because of this reduction in systolic dysfunction and this risk of heart failure. So now we're really in the phase of talking about what's next in class, and this is a medication called aficamten, as we've reviewed earlier. How might it differ from the mavacamten we just have been talking about? Well, in terms of efficacy, some of the data that we'll review coming up, safety and tolerability, and of course, ease of use. And aficamten was designed to leverage its distinct pharmacological profile to optimize these issues here. So let's take a look. So the key pharmacologic features are a once daily dosing with a half-life of 3 to 4 days, which is shorter to the other CMI in comparison. This allows for rapid dose adjustments every 2 weeks, as was designed and shown in the clinical trials, and rapid reversibility, again, a rapid washout should there be an adverse event or depression of LV systolic dysfunction. There's a wide therapeutic window, so that means there are just small changes in left ventricular ejection fraction as that dose of aficamten is increased, and then you can individualize that dose adjustment better for that individual. And then there are minimal drug-drug interactions. So there's, as far as we know, no clinically significant CYP inhibition or induction, again, really minimizing the risk of drug-drug interactions or patients, unfortunately, perhaps being prescribed something later after starting the drug that may interact. So let's run through the most current sort of phase 3 clinical trial data we have of aficamten in this population of symptomatic obstructive HCM. The SEQUOIA-HCM trial was exactly that, aficamten versus placebo in this group. And what you can see is, this is a zoom-in slide on the maximum peak oxygen uptake, again, that peak VO2 measurement of functional capacity. As you can see, a significant increase with the treatment with aficamten compared to placebo to the mark of 1.8 mils per kg per minute. And just to orient you to really what that may mean, I'm also a heart failure cardiologist, so this peak VO2 is a number that I pay attention to a lot. I'm sure many of you do as well, especially when we're considering outcomes like heart failure and progression to need for advanced therapies. And so in our world, the risk of death or transplantation in hypertrophic cardiomyopathy is reduced 21% for each increase in peak VO2 of 1 milliliter per kg per minute. As you can see, our least square difference here, again, was 1.74 mils per kg per minute. So really remarkable with a therapeutic here to hopefully reduce this risk of potentially long-term adverse events when it's related to heart failure. So similar data to what I showed earlier with regards to reduction in LVOT obstruction, Valsalva LVOT gradients. As you can see here, 68% reduction in these gradients below that threshold of 50 millimeters of mercury. And then the impact on ejection fraction, again, very modest, remained in the same very normal range, as you can see there, both by core red and sight red echoes. While there were instances of LVEF reduction, there was no instances of clinical heart failure, no need for interruption of treatment, and again, all of these reductions in systolic dysfunction were reversible in this study. And again, to emphasize, there were no serious adverse cardiovascular events associated with aficamten treatment in this trial. So then what was next? So this was a really exciting trial just presented a couple of months ago at the European Society of Cardiology meeting, the MAPLE-HCM trial. So really our first head-to-head cardiac myosin inhibitor versus beta blocker for obstructive HCM. So I told you the story of these therapeutics down the line from beta blocker in isolation, and now we had really the head-to-head trial really showing us what does cardiac myosin inhibition look like against beta blocker. So you can see here a randomized trial of 175 patients, either naive to therapy or on chronic standard of care therapy, randomized to afi versus metoprolol. As you can see here, similar endpoints to what you're used to hearing about already. So this change in mean peak oxygen uptake at 24 weeks. As you can see, aficamten had an increase in peak VO2, while metoprolol actually had a decrease in the peak VO2. So again, this medicine that we've been using to treat HCM patients for decades may actually be causing patients to feel worse. And this was a really remarkable way that we could demonstrate this in a randomized trial fashion. And again, With regards to MAPLE-HCM, there were these secondary endpoints, as you can see here, encompassing wide ranges of other measurements of how we measure how patients feel. That included the Kansas City Cardiomyopathy questionnaire, a questionnaire that was developed in patients with heart failure. We're now using in patients with HCM. It's been validated in this population. As you can see here, patients felt better both by clinician-assigned New York Heart Association class and patient-reported symptoms by this KCCQ questionnaire. Other aspects of cardiac remodeling and other things that you may think are adversely happening in HCM heart, like high NT-proBNP, high troponin, adverse cardiac remodeling measured by echo, like left atrial enlargement. All of those things were shown to be reduced in the patients who were treated with aficamten versus those with metoprolol. And again, you can see here very similar graphs to what you've seen before, the reduction in those LVOT gradients with rest and Valsalva over time with aficamten. And then, as I just mentioned, these markers of cardiac stress and stretch, NT-proBNP, and adverse remodeling, left atrial volume index, again, you can see dramatically reduced with aficamten. In terms of safety, we've listed here the aficamten compared to metoprolol events, with including any serious adverse cardiac event or anything that really led to early termination of treatment or withdrawal of either drug. As you can see here, really essentially no difference, and sometimes actually more withdrawal in the metoprolol arm compared to the aficamten arm. So again, really emphasizing the safety and tolerability of aficamten, even sometimes above and beyond with some of our historic HCM therapies. Something else we're looking at is other complications of HCM. As I mentioned before, these downstream complications of things like atrial fibrillation. Again, as you can see here, this compilation from many of the trials of aficamten in patients with HCM. Essentially, there's no further cardiac serious adverse events or reduction in EF in patients who may have new onset AF or atrial fibrillation after starting this medication, and a modest recurrent AF comparison in those who had atrial fibrillation history. And then we have long-term data. Now I'm showing you out to 168 weeks of these markers that we've been looking at, like LVOT gradients, ejection fraction, NT-proBNP. As you can see, the same themes that I've been echoing at 28 and 30 weeks persist all the way out to long-term therapy, 168 weeks. So this is really great data to have and to be able to talk with our patients about the durability and safety of these long-term therapies. Similarly, you can see with NYHA class out to 168 weeks, complete improvement in NYHA class, and similarly as measured with the Kansas City Cardiomyopathy questionnaire over time. So where are we with regards to drug approval status? We've talked about mavacamten already. With aficamten, the phase 3 approval decision is pending just here in a couple of months, and the European Association EMA, his review is ongoing. And then just a final word on non-obstructive HCM. So you'll remember that I mentioned about 2/3 of patients have obstructive HCM. We have the other third that has non-obstructive HCM. So what do we know about CMIs in this population? Well, we have one major trial with mavacamten called the Odyssey HCM trial. Again, that was mavacamten versus placebo non-obstructive HCM. Unfortunately, did not meet its primary endpoints, which were changed from baseline to week 48 in the mean peak VO2 in Kansas City Cardiomyopathy questionnaire. So you can see with the graphical representations there, really no difference compared to placebo in this population. And then similarly with their secondary endpoints, mild reduction in NT-proBNP and some improvement in symptoms, although again, not really significantly different between the mavacamten and placebo arms. Aficamten is also being studied in this population. We have not heard the results yet. This trial and the analysis is ongoing. This is called the Acacia HCM study. We're all awaiting these data with much excitement, but again, aficamten versus placebo in this non-obstructive HCM population. We're anticipating again to hear results in March at the ACC, American College of Cardiology meeting in 2026. And with that, that was a whirlwind view of our phase 3 clinical trial data. Now your head is spinning. I see everybody smiling in the audience. Hopefully I was able to emphasize some of the important concepts of this new therapeutic class and the differentiation between the two drugs that we have in practice and being studied. And now my colleagues will take it from here and we'll talk about the pharmacist's role, and then we'll come to some cases to really practice this clinical trial knowledge in real life.
All right. Thank you, Dr. Reza. Again, my name is Dr. Rachel Lavelle. I'm practicing at University of Chicago Medicine, working with a lot of these HCM patients, and so now I'd like to take you from the trial data to more of the role of the managed care pharmacist in CMI therapy. So just to review some of the population health characteristics that are relevant from a managed care perspective, again, this disease impacts around 1 in 500 young adults. It is inherited in an autosomal dominant manner. We know of about 1,500 mutations in 11 different genes at this point that could be associated with the development of disease, but diagnosis does not require a family history. It is relatively equally distributed by sex, and racial and ethnic distributions vary widely between data sets, and this could be related to the genetic bases as well as social determinants of health. The phenotype can vary based on the location of septal thickening and as well as the presence or absence of LVOT obstruction. You can see in the graphic on the right that sigmoidal HCM is the most common type, and this is also the most common type to cause LVOT obstruction, but there are several other phenotypes in relatively high prevalence. And in the context of CMI therapy today, the biggest differentiation is between obstructive and non-obstructive, which, as Dr. Reza mentioned, is based on a threshold of an LVOT gradient of 30. And for best management of HCM, it really is important to have a multidisciplinary team. And in fact, this is required for a center to be designated as an HCM Center of Excellence. So just to give you an idea of what all these many healthcare professionals may be doing in the care of these patients, the heart failure cardiologists will obviously be involved in medical management, as well as assessing when patients may need to progress to advanced therapies such as transplant. The electrophysiology team can help us with ICD implantation, as well as management of potential comorbid atrial fibrillation. And our cardiac imaging team is important for those echoes and cardiac MRIs, both performing and assessing that data. If a patient requires septal reduction therapy, there may be the involvement of an interventional cardiologist or a cardiac surgeon, depending on route. The sports cardiologist can help with athletic activity recommendations. The genetic counselor is really invaluable for screening of the patient, as well as potential familial cascade screening and counseling on the implications of that. And then the clinical pharmacist may be involved in drug selection, interaction management, potentially medication access, as well as nowadays CMI therapy monitoring. So as a clinical pharmacist myself, I can attest that the role of the clinical pharmacist in the care of these patients has really become greater since CMIs have become commercially available. And this workflow on the right is one center's proposal of a CMI initiation workflow, and you can see how intimately involved the pharmacist is throughout this process. So some of the steps that the pharmacist may be involved include the REMS enrollment and counseling, the drug interaction assessment and recommending alternative therapies, some of the enrollment in patient support programs and med access, potentially the echocardiogram scheduling and monitoring using that REMS protocol, the dose adjustments to the CMI, and then potentially even management of comorbidities such as hypertension and atrial fibrillation. And so with that clinical context in mind, we'll now move into more specific considerations for the managed care pharmacist. So first, when should CMI be initiated? Again, as Dr. Reza mentioned, the American guidelines do prioritize first-line therapy as either beta blocker, verapamil, or diltiazem. And all of these drugs work fairly similarly for their treatment of heart failure, or of HCM, and that's to slow the heart rate in order to prolong the diastolic filling time. And they may also provide some benefit by being negative inotropes. But it's important to remember that while these drugs may reduce symptoms, they do not address the underlying cause of disease. Then we have our equally weighted second-line therapies, beginning with our cardiac myosin inhibitors. Again, these reduce the actin-myosin cross-bridge formations, which leads to less contractility and less LVOT obstruction. Then we have our disopyramide, which is a class 1A antiarrhythmic. Here, for HCM, it's being used for its negative inotropic effect, but it can be especially helpful in patients with comorbid atrial fibrillation since it can effectively treat both disease states. And then we have septal reduction therapy, or SRT, which we'll discuss in more detail in a few slides. But ultimately, the choice between these therapies may come down to things like cost, comorbidities, and patient preference. Next, should first-line therapy be discontinued at the time of proceeding with CMI therapy? So let's review a few of these recent studies. First, beginning with a subgroup analysis of the Explorer trial. So in the original Explorer trial of mavacamten, there was a treatment effect seen of beta blocker, where patients on beta blocker had numerically lower improvements in their peak oxygen uptake compared to those not on background beta blocker. And this study looked deeper into that difference. Nearly 3/4 of patients were on background beta blocker therapy in that study. And this subgroup analysis confirmed that over 90% of those patients did have chronotropic incompetence, which prevented their heart rates from augmenting appropriately with exercise. And so the theory, which this study helped to confirm, was that the heart rate dependent measures used in cardiopulmonary exercise testing are the reason for the lower response in peak VO2. And indeed, they did have similar improvements in all heart rate independent measures, including NYHA class for symptoms, NT-proBNP, KCCQ symptomatology, and even LVOT obstruction. So the difference seemed to be largely based on those heart rate dependent measures. Next, in the Sequoia trial, again, we had a majority of patients receiving background beta blocker in addition to the aficamten. And here we saw, again, similar improvements in the peak oxygen uptake, both with and without beta blocker. But you can see that, again, the group receiving beta blocker did have a numerically lower improvement. I did want to note here as well that there was about 13% of patients on disopyramide. Those patients were excluded from the Explorer trial, but it does give us data that about safety of using all three of these drugs together potentially. And then finally, to touch on the most recent data, and again, a unique trial design, a different way of looking at this, with the MAPLE HCM trial, which compared aficamten monotherapy to metoprolol monotherapy. Again, we saw superiority of aficamten over metoprolol in this study in terms of peak VO2. There was no difference in adverse events between the two groups, and importantly, no increase in adverse events without that beta blocker background therapy in combination with aficamten. So overall, in determining whether first-line therapy should be continued, I think it's important to consider whether patients on CMI do have other indications for that beta blockade. If they have, for example, atrial fibrillation, maybe you choose to continue first-line therapy. If they're having adverse effects to their beta blocker or calcium channel blocker, maybe that's a patient who discontinues first-line therapy. But ultimately, this may become less of a question in the future, since the MAPLE HCM trial gives us potential superiority of CMIs, and so future drafts of the guidelines may actually escalate these to first-line therapy. Next, I think it's important to understand the differences between the two drugs, as Dr. Reza touched on. As of right now, mavacamten is our only commercially available agent, but we expect aficamten as early 2026, given its PDUFA date later this year. The half-life of aficamten is about half of that of mavacamten at about 3 to 3.5 days. And the drug interactions are different here. Mavacamten is primarily metabolized by the CYP2C19 enzyme, followed by the 3A4 enzyme. And so because of this, strong inhibitors of 2C19, as well as moderate to strong inducers of either enzyme, are contraindicated in combination with mavacamten. Weaker inhibitors of either enzyme can be used in combination, but they do require dose adjustments to mavacamten. Whereas aficamten was designed in a way to try to avoid a lot of these drug interactions, so we anticipate that there will not be any contraindicated drugs based on these interaction pathways. Potentially, moderate to strong CYP2C19 inhibitors may require dose adjustments, but that remains to be seen once the package insert is published. From a teratogenicity standpoint, mavacamten is known to potentially cause fetal harm, and so contraception is required for any woman of childbearing age. Whereas with aficamten, there have been no evidence of an embryo or fetal toxicity in the preclinical studies. And then finally, from a REMS perspective, mavacamten does have a REMS program for 3 reasons, both for the risk of systolic heart failure, for its drug interactions, and for its embryo-fetal toxicity. Aficamten is expected to also be mandated to have a REMS program, but likely just for that risk of systolic heart failure. And then finally, I think it is important to understand when your patients may benefit from a procedural intervention rather than a pharmacologic one. So SRT or septal reduction does benefit some patients. That can be either with a percutaneous procedure of alcohol septal ablation or an open surgical myectomy. Again, this is a second-line option, either if symptoms persist on first-line therapy or if the patient fails other second-line therapies potentially. there is some evidence that CMI therapy can actually reduce the need for these invasive procedures. First, the VALOR HCM trial, published in 2022, enrolled patients who all met SRT criteria at baseline. But again, looking at the graph on the right, you can see that 16 weeks of mavacamten treatment led to a minority of patients who still were eligible for that treatment, compared to a majority still in the placebo group. The SEQUOIA trial showed very similar results. So after 24 weeks of aficamten, 88% of patients who initially met the SRT criteria were no longer eligible after being treated with aficamten. And in the FOREST-HCM long-term extension study of aficamten, there are 19 patients who were enrolled there, met standard criteria for SRT at baseline. 0 of those patients meet the criteria ongoing after 48 weeks of aficamten. So again, shared decision-making is important here between patient and provider. If proceeding with SRT, it's important that it's done at an HCM center of excellence that has a lot of experience with either procedure that the patient is proceeding with. And I will note that the cost could be lower than CMI therapy, only because it is a one-time procedure compared to right now indefinite CMI therapy is recommended. So let's move into some utilization management strategies for how to manage this from the payer perspective, starting with prior authorization, or PA. This is typically handled as universal prior authorization at this point. And I think this is appropriate. It allows our payers to target the correct population, confirm the diagnosis, and avoid harm of these drugs to anyone who doesn't meet the current eligibility. And so typically these prior authorizations will require proof of an obstructive HCM diagnosis, symptoms at NYHA class 2 or 3, and an EF over 55%, as aligns with the REMS protocol. There is the question of whether the LVOT gradient should be included as a criteria, and I'll touch on this again when we come back to the case, but just wanted to note here that LVOT gradients are notoriously variable. There's a lot of factors that can change these from test to test, including things such as time of day, physical position, or even how recently the patient exercised. So in order to avoid delays in care, because those are so hard to standardize in a lot of cases, these typically can probably be avoided on the prior auths, since the general requirements are enough to identify the proper patients. Next, for step therapy. In terms of designating step therapy, I think this does align with the current American guidelines, since they recommend failure of first-line therapy before proceeding to CMI. But a requirement to fail multiple drugs may lead to delays in the best care for patients. For example, saying they need to try 3 or 4 beta blockers, or both beta blockers and calcium channel blockers, because again, these drugs all have very similar mechanisms, so we wouldn't necessarily expect much more benefit from trying a different drug in the same class. And given the new data we have from MAPLE HCM, we should really consider whether this step therapy requirement is still appropriate, given that CMI therapy has been seen to be superior in at least one trial to beta blockers, and the fact that it's the only drug addressing the underlying pathophysiology of HCM. And then finally, our REMS programs, which are federally mandated. Here, again, we have the requirement to monitor the ejection fraction ongoing due to that risk of systolic heart failure. I will note that for mavacamten, maintenance dose patients, the frequency of echoes did recently decrease from every 3 months to now only every 6 months. And so it brings up an interesting question of whether provider preference for how frequently the patient has those echoes for monitoring will ever exceed the minimum REMS requirement, and what that could mean from a reimbursement perspective. From aficamten data, we do see relatively limited echo yield. So of over 3,600 echoes from the aficamten data, less than 1% of those echoes led to a dose reduction in aficamten once the patient was on maintenance dose. So remains to be seen whether these requirements will change over time. But given the big risk associated with systolic heart failure, I think the REMS programs are appropriate and necessary for the time being. And finally, CMI therapy, we've got a ton of new data, but it's really still in its infancy. So there's interest in future roles to come. So the biggest, most obvious is in that non-obstructive population. As Dr. Reza mentioned, we had a negative trial with Odyssey HCM earlier this year, where mavacamten showed no significant improvement in peak VO2 or symptoms. But the authors noted that the response may vary by the specific pathophysiology of non-obstructive HCM, and that we may need different measurements, different biomarkers to really narrow in on what indicates clinical improvement. We have the Acacia trial that's ongoing and again expected in early 2026, so that'll help us know whether this is a class effect or whether aficamten has a role in these patients. There's also ongoing research in pediatric obstructive HCM, so the SCOUT trial in mavacamten, the CEDAR trial in aficamten, looking at patients ages 12 to 18, with CEDAR expected to expand to younger patients aged 6 to 12 in the future. There's interest in whether these drugs could delay disease progression in patients before they develop symptoms, so NYHA class 1, asymptomatic HCM, and then finally, in a much broader perspective, HFpEF, or heart failure with preserved ejection fraction, is another area of interest. There was actually a study published earlier this year, the EMBARK HFpEF study of mavacamten. This was a phase 2 trial which did show improvements in biomarkers and echo markers of wall stress, but the authors noted that they did not plan to pursue mavacamten further for this indication, instead pivoting to a different novel CMI. So we have the Aurora and the AMBER HFpEF studies, both phase 2, looking at novel CMIs for use in HFpEF. So as these trials are published, we may see a lot of expanded indications for these drugs, so definitely an area to stay tuned. And with that, we will move into a few poll questions just to assess your understanding so far. So if you've logged into the polling system, I'll go ahead and read through these options here. So which of the following is true regarding CMI therapy in patients with obstructive hypertrophic cardiomyopathy? Option 1, CMI therapy reduces symptoms but does not address the underlying pathophysiology in obstructive hypertrophic cardiomyopathy. 2, CMI therapy is a first-line drug therapy according to the most recent HCM guidelines. 3, systolic heart failure occurs as a result of CMI use in over half of patients who are prescribed this medication. Or 4, improvements in both peak VO2 and NYHA class are seen as a result of CMI therapy. Your answers, we'll move to the results here. And looks like most people did have the correct answer, which is number 4. Improvements in peak VO2 are seen as a result of CMI therapy. This is phrased a little bit differently here, but we see both improvements in peak VO2 and NYHA class. In regard to the other answers, CMI therapy does address the underlying pathophysiology in reducing the actin-myosin cross-bridge formation. It is not a first-line therapy according to the most recent guidelines. It still requires ongoing symptoms on first-line therapy such as beta blocker, calcium channel blocker, but given new data, we may see this change in future drafts of the guidelines. And then systolic heart failure occurs in a minority of patients, definitely under 10% in all studies out so far. All right, and poll question number 2. Which change to utilization management strategies would be a logical response to the findings from the MAPLE-HCM trial? 1 would be expansion of prior authorization criteria to include baseline NYHA1 symptoms. 2, discontinuation of the REMS program. 3, removal of a step therapy requirement. Or 4, increased frequency of echo monitoring per REMS. It looks like a lot of you have locked in your answers, so let's see the results. So a bit of a mix here. Actually, the correct answer is number 3, which most people chose, the removal of the step therapy requirement. This would make sense, because MAPLE-HCM showed CMI superiority with aficamten over beta blocker. While the guidelines have not been adjusted to reflect this, it would make sense to potentially be using CMI as a first-line therapy. And a lot of times we do have to make this change before we have guidelines that reflect that updated data. Expansion of prior authorization criteria to include NYHA1 symptoms. The MAPLE-HCM trial did still look at NYHA class 2 and 3. So right now, we don't have evidence for NYHA class 1. Discontinuation of the REMS program, this didn't give us any more data to say that we've eliminated the risk of systolic heart failure, so the REMS programs are likely still appropriate at this time. And in terms of increased frequency of echo monitoring, there was also no indication to say more events that would require more monitoring. And in fact, we've seen the mavacamten REMS program decrease in frequency in recent months.
Thank you for that. Dr. Riza and Dr. Lavelle have really talked about the diagnosis and the management. I am going to talk about some of the access and barrier issues. Usually, typically once the diagnosis is made, the battle is half fought. A lot of these patients, without a team that really helped them to get it, they end up not starting it or not able to. I would say, when I was starting out as an inpatient pharmacist, did not come on my radar at all. And then 5 years ago, when I transitioned to outpatient, a lot of my job had to do with this as well. Because without getting it, there's no drug to manage, right? So, in the cardiology world, what we used to were maybe like Entresto, Eliquis, right? You get a copay card, or it's a little bit higher copay, but no problem. But when you get into specialty medications such as mavacamten, things become a little bit more complicated. One, our patients are not knowledgeable in this at all compared to other disease states. So the education starts from ground zero. The model for this looks different across the nation. And I think each clinic has their own pathway to get mavacamten for patients. This is just an example of what our center does. So when we have a patient who get referred to us, they'll see a cardiologist such as Dr. Riza, who will diagnose the patient, and we'll discuss treatments, lay out all the options with them, including clinical trial options. So you can see there were many different clinical trial options. And if the center is enrolling center, they can also be enrolled in that. If we decide that mavacamten is a choice that both physician and the patient decide to go with, then they'll refer the patient to me. And then I will look over, make sure all the data that we need are in the notes. And then we'll run through drug-drug interactions, make sure there are no medication that needs to be adjusted beforehand. And then we would enroll them in REMS and start the prior authorization process. All this process can take a day or two, just depends. And once we get the PA approval, then we will check on the copay, okay? And then based on that, if patients say we can afford it or not, then we go through the financial assistance pathway to get them assistance to help the copay. Once that's all settled, then we will decide when patients should start, and we'll order the echoes for them to schedule, so then we have the timing right. If you schedule the echo too early and the patient have no access to the medication yet, then the timing will not work. Because per REMS requirement right now, you need echo once a month for the first 3 months, and if you're stable after that, will be every 6 months. So you really want to get the timing correct in the beginning, or at least in the ballpark. That way, we will not be either run out of medications or things like that. And then at the end, patient will start mavacamten, and I'll continue to manage them throughout, and I'll show you a little bit of that as well. Some of the barriers to access from our perspective, again, it's a specialty medication, and this is a new concept for a lot of our patients. So the education needs to be done. A lot of them ask me, what can I just pick up at CVS? What's the difference? Or what can I talk to somebody? They don't like to talk on the phone, they like to talk in person, but that physical medium is not there for them anymore. As we know, specialty pharmacies are mostly mail order, and they rely heavily on telephone communication. Insurance, obviously, with the prioritization criteria, the process, the copay, the financial assistance, all of that is another barrier in itself. REMS program is a safety net, right, for this medication, but it can cause a lot of delay as well. After each echo, the cardiologist will review it. We would submit the data onto the patient portal, and once that's logged in, the specialty pharmacy then can allow certain pills to dispense. So without echo, without the submission, there's no drug. So you can see that the time delay in between of that, even 1 day apart, can cause a couple days before they can even receive it. A quick overview of specialty medication. I know a lot of us know about this already. Is categorize it because of its drug property or special storage or administration, or special side effect profile like ours is reduction in ejection fraction or high cost, which mavacamten also is. It usually treats serious or often life-threatening conditions like cancer, rheumatoid arthritis, or cystic fibrosis. It has a special access required by the manufacturer or payer. So a lot of these pharmacies are contracted with manufacturers. So there's only a couple of them. There is limited distribution. The pharmacy itself is state licensed pharmacy just like others, but there's actually not a separate category for specialty pharmacy. The board would make sure they meet standards for safety and legal dispensing of the drug, in particular for special handling and patient education. Those two parts are usually what a specialty pharmacy would do for patients on mavacamten, is the education and REMS. As far as coverage, there's a variety of insurance in the United States, unlike other countries. So, to navigate this sometimes can be very difficult if you're kind of new to this. But we kind of have to just start from scratch when we first started this, because we were a clinical trial center and all the patients were rolling out of the trial. Well, when mavacamten got approved, and then we had to kind of figure out, okay, so how do we transition this so they don't miss the next dose? So, we kind of had to figure it out on the spot in a month or two. It was fun, but also challenging at the same time. So depending on the insurance, the copay assistance were based on your income level or their income level. There are some foundation grants for Medicare patients. You have to meet certain federal poverty level, usually less than 500%. And then there's also assistance from the manufacturer side if all the assistance program fails. Again, that's based on income. The manufacturer also offers copay card program like all the brand name medications, but it has a max benefit of $15,000 per year for mavacamten. They also help cover the copays for the echoes up to $2,500 per year, which is nice. Some patients plan have this special group called accumulator or maximizer, which they used up all the benefits from the copay without paying its deductible. So what you can, with that, patient's copay card will run out really fast. They end up with big copay at the end. And then all of the patients are eligible for the free trial, which is 5-week supply, and we really encourage them to take the opportunity to get it because that can really set them up for success in terms of setting up the echo early, and then you have a little bit buffer with the free trial. This is a financial assistance pathway that I kind of briefly mentioned, so it kind of depends on the type of insurance. If you're commercial, you have the copay card, then your copay is as little as $10. For the state/federal, you have a couple options. Medicaid, if you get it approved, then copay is really fully covered, obviously. If you have Medicare, you will have copay up to $2,000, right? So we know this year they took away the coverage gap. So every patient have an annual of $2,000 maximum to pay for all the prescription drugs. So this is actually advantageous for them if they can afford it, because that will also take out all the copays for other medicines, like if they're on Eliquis or something like that, because the copay will be zero as well. Most of them qualify for the foundational grant because their income is lower than 500% federal poverty level, and then they'll just take care of the $2,000 right on the front, and then they'll be good for the whole year. For the VA patients, the physician process is all separate. It's on their own. So you have to submit the PA to them. They have to review it locally with wherever the VA they're contracted with. The copay is usually $11. It's a tier 3. For TRICARE, it's different. than the VA itself, but once it's approved, copay is about $43, and there's no assistance for that. You just $43. And then for non-insured, again, it's based on your income level. If it's low enough, then you can apply the assistance through the manufacturer and get it for free. Okay, so all of these pathways involves, documentation, so paperwork and all of that. So without a team to really help them, this can be hard on their own. This is just, I was mentioning about the federal poverty level. So if you look at 138%, that's usually where Medicaid's threshold is. So if one person household makes less than $22,000, they'll qualify for Medicaid, right? For two people, it's less than 30. For those assistance programs, usually should be less than 500. So 500 on the bottom, they need to make less than 78,000 or about 106,000 for two people household. A lot of our patients are middle income retirees, so they will qualify. But if you make a little bit more than that because you have like extra pensions or you took out from your retirement fund, then they will not qualify. They were stuck with the $2,000 copay, right? But even before that was even harder because they had donut hole to even, deal with. A little bit about the formulary review process. Each insurance plan is different, but in general, they look at these things when they review a new drug, right? What is the classification that FDA approved on? Is this a new active ingredient? So Mavacamten was, right, is a novel ingredient, Cardiomyopathy inhibitor. Were there any other similar drugs to compare with? There wasn't at the time, but now aficamten is coming out, so that will be a comparison when aficamten is being reviewed. The guidelines that Riza mentioned will obviously be something that they will look on the background as they go down the process. They'll also review clinical trial data, the landmark trial. A lot of them are approved based on Explore-HCM, the pivotal trial. Head-to-head studies, there were none before, but recently there's the Maple-HCM that both of them mentioned, compared with beta blocker. So that should be reviewed on this upcoming year, hopefully. So then some of the therapy may be reconsidered. Safety, there is a box warning for ejection fraction reduction, so therefore the REMS program as well. Cost comparison with a lower tier beta blocker or non-dihydropyridine calcium channel blockers, as well as disopyramide. Those will be compared. And then for CMIs, it's specialty tier. Now, they usually will want some kind of cost-effective evaluations, right? Because this is where insurance plan will look and see, is this worth it? How do we make it worth it or justify for the patient? There was only one study done before Mavacamten even rolled out, and they look at, it determined that the cost-effective drugs are usually about $12,000 to $15,000. The listing price for Mavacamten was about $103,000 for a year. Obviously, that's 7 times higher than was suggested. And then compared to standard of care, the first-time therapies or SRT, the septal reduction therapies, like the surgeries, Mavacamten had a cost of $1.2 million per quality adjusted life years. The number looks really large, so a lot of times it's hard to even think about justifying it. But this is all contextual, right? You have to look at the individual patient. Just because they have not tried the first-line therapy does not mean they should not even consider CMI at all. And some of the quality of life really matters to them. A lot of patients on beta blocker for years, they are still laying in bed, can't do anything. And once they started CMI, they can go hiking now. So those are the things that sometimes a cost-effective evaluation cannot tell you. So, these are the things that insurance plan can really help you decide, but also we have to look at the individuals as well. Some of the commonly included criteria, we kind of talked about this already, but in the notes, usually you want to make sure there's a diagnosis confirmed. The imaging studies, usually we look at stress echocardiogram. to look at the ejection fraction. Let's make sure it's greater than or equal to 55%. And you have LVOT gradient that's equal or greater than 50. And then they usually like to see a history of medication that they have tried, the standard of therapy that I mentioned. And then they want to make sure it's prescribed in consultation with the cardiologist. This is something that's interesting. The typical denial reasons, they usually say, oh, they have not tried a beta blocker. And then if you say they tried metoprolol already, they say, oh, you need to go ahead and try bisoprolol, propofol, all of them. Or they will say you should try a calcium channel blocker as well. Some of them will even say you should try either beta blocker or calcium channel blocker plus disopyramide. So each insurance plan has different kind of rules. It's very interesting. And some of them will even ask you to try, oh, the patient is only on metoprolol 25, can you maximize 200? Just things like that. It's interesting, but also sometimes they are not really, they are not taking care of the patient. They don't know the patient obviously can't even go up to 50, right? Some plans will also suggest to try surgery because obviously surgery could potentially be a cheaper option. But again, those are the things that we want to make sure we include in the notes so that the insurance plan knows why all these options are not the best. Once in a while, there will be a patient who they needed more than 5 milligrams of mavacamten. And when we push to 10 milligrams, they don't do as well. But it does not come in 7.5. So we end up doing 7.5, which is 3 capsules of the 2.5 milligram, and we run into some issues with that as well. Other barriers, the echocardiogram scheduling can be hard, right? If it's internal, it's easy. You get it, make an appointment with our facility, which is already all in one place. But if it's an external facility, like a lot of our patients come from the rural areas, so we say, hey, you need to schedule echo in your local hospital. We never heard from them again. Either they didn't know how to schedule, or the order didn't get sent, didn't get authorized. There's many kind of issues that you can kind of anticipate, but if no one's following up with this, they will just end up not starting because they don't have the help they need. And some of the facilities that is not specialized in HCM, when they do the echoes, the reading might be off as well. And our cardiologists like to read all the echoes from mavacamten, and when they look at some of these ones, he will be suggesting we should reduce them because they are not good quality. The REMS we kind of talked about, the delays can really happen if the echo is not done on time. Patient status form is not submitted. They only allow 35 days maximum per dispense. Unless you are 1 year in, then you can get 90-day supply if your insurance covers. So you can see if patient want to go on vacation, that might run into some issues, or they go all over the country. We have a patient who went to Taiwan and said, how do I get my medication? And he didn't know it can be mailed overseas. So, he kind of have to help them navigate that. This diagram Dr. Lavelle showed earlier, medication like this really involves everybody on deck to help patient get it and manage it. And each center have different role they play. But for the most part, these are the things that somebody should be in charge of, right? In our center, we have a very small team. So basically, once it's prescribed, I just took over. Again, each center is different, but all these roles need to be fulfilled in order to make it successful. In summary, specialty medication is becoming more prevalent, but access remains challenging. The treatment decision should be centered around share patient and provide discussion. Multidisciplinary approach between physician, pharmacist, nurse, and coordinator is key to address barriers. And collaboration between Center of Excellence and community providers is also important. We have patients who just come to see us a couple times, once a year at most, and then the rest of the time they spend in their communities with their local providers, and then we can kind of collaborate with them as well. That way you don't have to travel 3-4 hours just for one echo. With that, we'll go through some cases, more relaxed part, and then we'll have some Q&A at the end. So if you have any questions, make sure you submit them, and then we can kind of talk about them as well. So I'll do the first case. It's a newly diagnosed patient. 39-year-old woman with past medical history of non-obstructive coronary artery disease and hypertension referred to our clinic. She reports unable to climb more than 1 flight of stairs without stopping to catch her breath and mild chest pain at rest. So the symptoms is pretty bad. She is on aspirin and losartan so far, and her vitals is 135/77, so a little bit elevated. Heart rate is 54, low. Her stress echo showed ejection fraction was 65%, and then peak LVO2 gradient is 42 at rest and 84 with Valsalva. Okay? So with this information, which of the following is the best classification of this patient's symptoms and the best recommendation for the first-line treatment? Is it 1, this is non-obstructive hypertrophic cardiomyopathy, and we should increase the losartan to 50 milligrams once a day? Or is it number 2, apical hypertrophic cardiomyopathy, and we should switch aspirin to apixaban 5 milligrams twice daily? Or is it 3, obstructive hypertrophic cardiomyopathy, and we should switch losartan to verapamil 120 milligrams daily? Or 4, diastolic heart failure, and add furosemide 40 milligrams once daily. Give you a couple seconds to do that. Okay, so most of us picked the third option, which is correct. It's obstructive hypertrophic cardiomyopathy, and we just switch losartan to verapamil 120 milligram. And as you can see, the next slide. This is the guideline that Dr. Riza presented earlier. With obstructive physiology, your LVOT gradient should be, equal or higher than 50 to be treated. And then you should avoid vasodilators, right? So losartan is a vasodilator that potentially make obstruction worse. So you should actually get rid of it and then switch to something else. So the first-line treatment here, the verapamil, will be good for hypertension as well. And with that, I'll give Dr. Riza for the second case.
All right, so this is one of my patients, Miss C, who came to me. She was short of breath. She was 63 years old at the time that I saw her in clinic. And dating back to when she was a child, she never thought that she could keep up with her peers as well as they could in terms of exertional activity, playing sports. She was diagnosed with hypertension in her 40s. Her primary care provider heard a murmur on exam in her 50s. And then she came to see me with dizziness and shortness of breath, and she thought, I just thought this is how it is with natural aging. I just thought this is how you're supposed to feel when you're 63 and you have high blood pressure, and am I wrong? And so we did an echo. And some of you may be familiar with looking at echocardiograms, but this is a transthoracic echocardiogram. This is an apical 4-chamber image, and this is zoomed in on that left ventricle. What you see there in the sort of bottom third of the screen is the mitral valve, left atrium, mitral valve, left ventricle. As you can see, she has some asymmetric left ventricular hypertrophy there at the septum, and you can see that systolic anterior motion of the mitral valve causing this rainbow torrent of color, which is left ventricular outflow tract obstruction. So you can see all of that turbulent blood flow right there in that left ventricular outflow tract going out the aorta. Again, that's LVOT obstruction. So you may be even thinking, just looking at this rainbow, that this looks pretty severe, and it was. It definitely measured in excess of 50 millimeters of mercury, as we've decided. So we did, as our guidelines say at the time, to put her on first-line therapy. So I prescribed long-acting metoprolol. And here is her patient portal message to me a couple of weeks later. So she said, yes, I've been taking it twice a day as you suggested. I've also increased my water intake dramatically, and I believe it's made a difference. I am less winded after climbing stairs. She didn't say I'm not winded, she said I'm less winded. So I took that as a win, but I also thought we could probably do better. She's probably got more symptoms that she's not telling me about in this patient portal message. So I brought her back to clinic, did some more provocative testing. Here's her electrocardiogram. You can see her heart rate's right around 60 beats a minute. So not a whole ton of room to keep pushing that beta blocker dose. And then we did another echocardiogram provoked with Valsalva here, and you can see her pressure, a gradient across that LVOT gradient is measuring almost 80 millimeters of mercury still despite this treatment and despite a heart rate of 60 on metoprolol. So of course, we went back to our guidelines, and we're at the phase now where we can offer that if symptoms persist level of therapy after a beta blocker, 9-dihydropyridine calcium channel blocker, and so I offered her a cardiac myosin inhibitor. And so I wanted to actually just show you and share some of our real-world experience from the University of Pennsylvania program, another large HCM center of excellence. This is some of our really early data that we looked at our patients who were prescribed mavacamten just after the initial 36 weeks. And you can see some of the concepts that we were talking about earlier, and these data very similarly mirrored what was seen in the clinical trials with regards to the dosing of mavacamten, proportions of patients that were on the starting dose of 5 that got reduced to 2.5 at which steps of therapy, and which of those got actually dose increased at what time points at 10 and 15. And then on the right, you can see this concept of what we were talking about earlier, dose de-escalation of background therapy. So again, AV-NB here is AV nodal blocker therapy. So you can see by 36 weeks in our real world experience, about 14% of patients were actually able to decrease their dose of background therapy. And this has actually also been studied with regards to aficamten in particular in the FOREST HCM, the long-term extension combination aficamten clinical trial studies looked specifically at standard of care medication withdrawal in these patients after they completed a trial investigating aficamten. So you can see the study schema seen here when attempt of withdrawal was made and then when the assessments were made post-withdrawal. And these are just sort of showing you the study diagram and the disposition of patients according to their standard of care withdrawal therapy. So 145 patients were followed for more than 24 weeks. 94% remained on aficamten plus standard of care therapy. And then there was an attempt to, again, withdraw in a subgroup, and then 53% in the control that did not undergo attempts at standard of care withdrawal. And then what you can see here, 92% in the successful withdrawal group, again, 39% of those were able to have aficamten up titration. So again, when you attempt to withdraw standard of care therapy, again, after you've achieved your therapeutic response with the cardiac myosin inhibitor, especially aficamten here, you're able to successfully withdraw the standard of care medication. So you can see 64% discontinued at least one of the standard of care medications. 71% were able to achieve aficamten monotherapy, and a small percentage, 7%, did have to restart the standard of care therapy. And in our clinical experience, as Rachel mentioned earlier, we find this, again, to be those population of patients that have a separate indication for a beta blocker or a calcium channel blocker. So what happened to Miss C, my patient? She, again, came to me dizzy and short of breath. We escalated her therapy, got her on a cardiac myosin inhibitor, again, prescribed per our current protocols, and now she's sustained on CMI therapy. Her EF has not dropped. She remains at an EF threshold above 55%. We're able to decrease that beta blocker dose after she achieved hemodynamic response with the mavacamten. And remember, I showed you her heart rate hovering around 60 on that EKG. She didn't really feel well at a heart rate sort of that low. She was an active woman. So actually reducing that background beta blocker dose was actually able to help her even regain more functional capacity, as you saw even reflected from the clinical trial data I presented earlier, now here to real life. And so she's living her life, feeling not winded at all climbing stairs, and able to do a lot of the things that she loves doing.
Great. And for our case 3, this is also based on a patient at our center, talking a little bit more about the long-term management and pharmacist collaboration. So patient CH is a 55-year-old male. He comes to his advanced heart failure cardiologist for follow-up with complaints of worsening fatigue and ongoing dyspnea with minimal exertion, so NYHA class 3 symptoms, after his metoprolol was recently increased from 50 twice a day to 100 twice a day. He was previously a runner, and since he was diagnosed with HCM in 2023, he's been frustrated by his ability inability to race. He also has hypertension and GERD. So for his medications, he's on lisinopril for his hypertension, metoprolol tartrate, again, recently increased to that higher dose, and omeprazole 40 milligrams daily for his GERD. He has normal blood pressure, a borderline bradycardic heart rate, and normal oxygen saturations. His echo a few months ago did show an EF of 72%, so a bit hyperdynamic, a thickened septum, which we expect that systolic anterior motion of the mitral valve was present. And he did have an LVOT gradient, a little bit lower at rest, but progressed to 67 millimeters of mercury with Valsalva, which probably explains his symptoms with exercise. Another thing to note, he does have commercial insurance through his employer. So our treatment options, going back to the guidelines here, we could increase his beta blocker dose or consider alternative first-line therapy, but there is likely diminishing returns at doses beyond 200 milligrams per day of metoprolol. His receptor sites are likely saturated, and we're already limited by a heart rate in the low 50s. Diltiazem or verapamil, as discussed earlier, are unlikely to help his symptoms significantly since their mechanism is very similar to beta blockers. We could switch to or add disopyramide, which would give us additional negative inotropy, but this patient does not have atrial fibrillation, so not quite as strong of an indication here. We could switch to or add mavacamten, our commercially available CMI, or refer for SRT, and again, needs to be performed at an experienced center with the patient comfortable with those surgical or procedural risks. So after discussing all these options, CH is most interested in trying mavacamten. He doesn't want to undergo those surgical or procedural risks. And so our plan as a team is to reduce his metoprolol back to the 50 milligram dose because he developed more fatigue on the higher dose without any improvement in symptoms. So back to that dose he was comfortable with. And then we decided to initiate mavacamten 5 milligrams daily. So first, on the side of determining how to initiate CMI, we looked, is he initially eligible? His prescriber is a REMS-certified provider for mavacamten, and from a patient perspective, he meets those criteria. He's symptomatic, he has obstructive HCM with an EF over 55% on his most recent echo. Then we look at drug interactions, and omeprazole 40 milligrams daily is actually a moderate CYP2C19 inhibitor. So for this patient, we decided to switch him to pantoprazole instead, which does not have that same interaction. Another option would be to start mavacamten at a lower dose, but the patient thought this was an easy enough switch to make before starting. For the REMS counseling, we addressed the drug interactions. This is not a woman of childbearing age, so we're not worried about that factor. And then he was willing to comply with echoes and understood the risk of the systolic heart failure. Then from a medication access standpoint, enrollment in the patient support program to help him access copay cards, echo reimbursement, because this is a commercially insured patient. As Dr. Chen mentioned, the copays for Medicare patients can be more difficult, and so this may be the point where you pursue grant programs or patient assistance programs. From a prior auth perspective, he meets all the basic criteria that are on most universal PAs. Step therapy could be a point where he experiences a delay because he has only tried metoprolol. But if this is a point where you receive a denial when pursuing mavacamten, it's worthwhile to appeal that decision, just given the targeted mechanism of mavacamten and the potential superiority, especially with the new data from the MAPLE HCM trial. Or, if that appeal is denied, you could perform a short trial of those alternatives, perhaps a calcium channel blocker. And again, as Dr. Chen mentioned, this drug does have to come from a REMS-certified pharmacy, so usually the payers will designate which of those certified pharmacies that they would prefer. And I want to just pause here for a moment just to talk about the LVOT gradients. So, patients can have obstruction at rest or only with that provocation or exercise. So with a threshold of 30, you could say, this patient is not obstructive at rest, but is with Valsalva and with exercise. And just looking back at our trial inclusion criteria, the Explorer trial allowed for any peak LVOT gradient over 50, whether that's at rest or with Valsalva or exercise, whereas the Sequoia trial of aficamten included patients with both an LVOT gradient over 30 at rest and over 50 with Valsalva. So this specific patient wouldn't meet the exact inclusion criteria of Sequoia, but it remains to be seen, how that will be applied from a payer and prior authorization perspective. From the mavacamten REMS program perspective, Dose adjustments are based on LVOT gradient with Valsalva. So this patient, we would be basing it on that baseline of 67 millimeters of mercury. And as mentioned before, our LVOT gradients are very variable. So there's a push towards goal-directed Valsalva. There's an example of this on the right where patients are asked to blow through a syringe connected to a sphygmomanometer, which allows them to see that they're maintaining a certain pressure of bearing down for a certain period of time. And if that can be replicated on each follow-up echo, it's easier to see more reliable changes in the gradient in response to therapy. We've talked a lot about how first-line therapy, the majority of patients in the Explorer trial were on background beta blocker therapy with another 17% on calcium channel blocker. But now we have data from MAPLE looking at aficamten monotherapy compared to metoprolol monotherapy. Unfortunately, there are no similar head-to-head studies with mavacamten, but we can likely extrapolate this to the rest of the class. The one consideration is that if we did choose to stop a beta blocker, atrial fibrillation and or hypertension could occur in greater frequency. And in fact, with mavacamten specifically, there's a higher incidence of atrial fibrillation in patients on mavacamten compared to placebo, and that's irrespective of background therapy. So for patient CH, he got those first 3 echoes as required, and you can see that his ejection fraction did decrease some over the first 12 weeks, which is expected based on that decrease in contractility. His resting gradient dropped from about 21 to 10, and his Valsalva gradient from 67 to about 35. At this point of follow-up, he reported some improvement in symptoms, NYHA class 2 rather than 3, and he did note a few missed doses between his second and third echo due to a shipping delay on the side of the pharmacy. But based on the REMS protocol here, which recommends a dose increase for a Valsalva gradient over 30, we decided to increase mavacamten to 10 milligrams daily for this patient, and then that requires a recheck of his echo in 4 and 12 weeks. So in between here, he of course should be monitoring for any signs of new onset heart failure. Each refill will require a check of any new drug interaction, so any changes to medication should be reported to the specialty pharmacy. And then in terms of that adherence issue, it's really somewhat out of the patient's control, but thankfully these drugs do have a relatively long half-life, so the efficacy should not be impacted just from that short-term adherence issue. Changes in ejection fraction, like we said, we expect some drop. We would interrupt therapy if it ever dropped below 50% and potentially resume at a lower dose. But no new starts or dose increases should be performed if that patient's borderline between 50 and 55%. So 3 months later, after completing that 4-week and 12-week echo on the higher dose of 10 milligrams daily, we see significant improvement here. His ejection fraction seems to have stabilized around 65%. He now has no resting LVOT gradient, and his Valsalva LVOT gradient has dropped to only 14 millimeters of mercury. At this point, the patient reports NYHA class 1 symptoms, and he actually was able to run a half marathon without issue 2 weeks ago. So really a success here. We decided to continue mavacamten 10 milligrams daily, and per the REMS protocol, just recheck the clinical status in 3 months and another echo in 6 months now. So given all these logistical and clinical considerations, I think there's a lot of pieces involved in initiation and monitoring, especially for that systolic heart failure, but we've seen that the risk is low once patients reach that maintenance therapy. And as seen with this patient, we can really see significant benefit from the initiation of CMI therapy and the collaboration with the pharmacist. And I'll pass it off to Dr. Chen to wrap us up here.
Yeah, so if you take away a couple things today with all we talked about. First, despite being most common inherited heart disease, HCM remains underdiagnosed due to various factors. Mavacamten, being the first approved CMI, has expanded the therapeutic landscape for obstructive HCM. And then aficamten, which is going to be reviewed by the FDA, is currently under review, and it will be the second class with shorter half-life and fewer drug-drug interactions. Lastly, initiation and management of mavacamten requires a multidisciplinary approach to ensure its success. And I guess I'll also include that, rethink about beta blockers, just, with all the data that's coming out as well. We have a few minutes left, and I have some questions here, so I'm gonna pick a few so we can talk about them. I think the first one, this actually, we actually encounter a lot as well, so I think I'll ask Dr. Riza for this. What are some recommendations for management of hypertension in obstructive HCM patients who remain uncontrolled on the standard care of therapy or CMI?
This is a great question.
Yeah.
And I actually just published a paper on this.
Yes.
And it's out in JACC Heart Failure a couple weeks ago, hopefully with some more data to come. So I want to make sure I got the question right. So I think there are two major issues. There's when you don't achieve hemodynamic response with your CMI, meaning you don't have reduction in LVOT obstruction. And then what happens when you do? Obviously, what happens when you do is an easier one to answer, so I'll take that one first. Mm-hmm. And so in our experience that we published, and we have now sort of both the clinical experience and hopefully generating some research data to help others in this space, because we realized from taking care of these patients it is an issue. We found that when we started to achieve hemodynamic response, reducing the LVOT gradient, it's very similar to what was found in sort of the early days of the TAVR experience. When you reduce that obstruction, the blood flow getting out of the left ventricle, more blood gets out, blood pressure goes up. And so we just started noticing clinically, we get LVOT gradient reduction, patients are then stable on their mavacamten dose, but then we're chasing blood pressure. Mm-hmm. And systolics are going up 150s, 160s. Again, in our patient population that we're looking at, our median age in our cohort is very similar to what was in the clinical trials. These are patients who are already 60 years old, many cardiovascular comorbidities as well. In our real world experience, we found more CAD, more AFib, more hypertension. So again, these are patients you do not want to leave hypertensive, right? They're at risk for other additional cardiovascular adverse events. So we started to take the approach of looking at the holistic data in HCM with regards to other primary prevention, sort of first-line antihypertensives using the 2019 ACC-AHA guidelines, and looking at essentially what is the first-line recommendations for those therapies, what has been studied in HCM, and how can we sort of bring these worlds together. So in our patient population, we started to use ARBs more specifically in particular, largely because of the evidence in HCM, like the VANISH trial and other historical studies that have been done showing potentially reduction in progression of HCM using those therapies. So ARBs were preferentially our first-line antihypertensive therapies as we started to ramp up our therapies. And then I would say sort of second line, we started to use, again, looking holistically at the HCM data, were mineralocorticoid receptor antagonists, given the totality of the data for HCM and hypertension control in that area. And this was, again, of course, on top of this landscape of potentially withdrawing the beta blocker, calcium channel blocker in the background. So we're sort of counting all of that as well. So in our paper, we show the sort of curves of the rise of systolic and diastolic blood pressure, and we found that actually controlling for all of those things, including age, sex, race, background, BMI, that blood pressure will rise about 4 to 5 millimeters of mercury, systolic and diastolic, over the course. We saw a peak in our population about out to week 60, but that curve sort of stays elevated, so patients do experience that rise. Hopefully further data that's under review now, and we hope to publish soon, we're actually breaking down these specific antihypertensives and how we're prescribing them, just to, again, share our clinical experience in doing this. We found that ultimately in our cohort, 20% of patients needed new introduction of antihypertensive therapies after they achieved hemodynamic complete response on CMI therapy. So it's a big proportion of patients, and this is, again, another cardiovascular risk factor that you have to keep your eyes on as you fully establish patients on CMI therapy. Those patients who do not achieve hemodynamic response, it's a tough one, right? Because they're still obstructed, and so if you're giving them vasodilators and diuretics, again, you run the risk of worsening obstruction. So we tend to, again, let those patients just run a little bit of a higher blood pressure because of that reason. We're not as strict as maintaining the guideline recommended 120/80 because of this issue in those patients. But again, we try very hard to reduce that LVOT gradient. And if, again, we can't do it through pharmacological approaches, then we pursue mechanical approaches with septal reduction therapy.
Yeah. That's all the time we have today. Sorry we didn't get to all the questions. Thank you guys for spending your 90 minutes with us. Really appreciate it. And if you to claim your credit, the QR code is there. I think there might be a survey as well. So thank you guys today.